Hello, thanks for joining us today on the DNS YouTube channel. My name is Britta Brown, and I'm a dietitian in Minneapolis, Minnesota. And today we're just going to spend a little bit of time rethinking how we assess energy and protein needs in critical illness. So, if you're like me, maybe some of the newer trials that were published last year have you a little bit confused. So, today we're going to take a few minutes and talk about the EFFORT protein trial, which was a study looking at the effect of different protein dosing levels in critical illness. And then the second trial we're going to look at is the NUTRIREA-3 trial. And this was a study that looked at both low calorie and protein feedings compared to standard calorie and protein feedings based on current practice recommendations. So first and foremost, when we think about protein needs in critical illness, we do have to recognize a few hard truths. And the first one is that we really don't know what the optimal protein dosing is in critical illness. And if you've been working for a while and you've read a lot of these papers, you know that the quality of the evidence is pretty low. And sometimes the researchers aren't able to even get enough difference between their study groups to be able to determine a difference between the control and the intervention group. And then the last thing we need to recognize is we really don't know if it's possible to be too much of a good thing. So intuitively speaking, we certainly think maybe more protein might be better, but we don't necessarily know if that's the case. And then the other thing that's interesting to me when we're thinking about protein needs in critical illness is that our practice recommendations are all over the map. So they can be anywhere from 1.2 to 2 grams of protein per kilo. And then if we look at other subgroups, for instance, patients with obesity or those requiring continuous renal replacement therapy, some of those protein recommendations are over 2 grams of protein per kilo. Adding to that, when you look at some of the studies that have examined how much protein our patients actually receive, such as the Canadian Critical Care Quality Improvement Registry, sometimes patients might be only getting as low as 15 on up to 100% of the amount of protein we prescribe. So you can see that protein dosing and clinical guidance in this area is certainly needed because it's been confusing to say the least. So with that in mind, I want to take a few minutes and talk about the EFFORT protein trial. And again, this trial was just looking at protein dosing, and the researchers wanted to see, is there a benefit in clinical outcomes between providing high protein during critical illness, which they defined as 2.2 grams of protein per kilo, compared to usual protein, which is 1.2 grams of protein per kilo. And you can see that unlike prior studies, this is at least a nice sample size. And with that in mind, they really were hoping to be able to see some clinical differences. And the fascinating thing about this is that they were successful in seeing a difference between the two study groups. So the high protein group that they wanted to aim for 2.2 grams of protein per kilo actually received 1.6 grams per kilo, and the usual protein group got 0.9 per kilo. So even though it wasn't a 1 gram separation between the two study groups, it was 0.7 grams, which isn't nothing. And then both groups received similar calories, about 13 to 14 calories per kilo. But interestingly, when they looked at all of their primary, secondary, and tertiary outcomes, such as the usual things you would think of, like hospital discharge, mortality, mechanical ventilation, ICU length of stay, there was no statistical difference between the two study groups. And I think this was certainly surprising to a lot of people who were maybe thinking that higher protein would be beneficial in the critically ill population. So not finding anything with their primary study objectives, they did do some subgroup analysis, particularly looking at the subgroup of patients that had higher severity of illness based on those SOFA scores. And for those patients in the higher protein group, they seem to have more ureagenesis. And they seem to think that maybe this represents some degree of protein intolerance with those patients with acute kidney injury and multiple organ failure. So they hypothesized that it's possible that this altered renal function in conjunction with impaired muscle protein synthesis was making them maybe less able to kind of, quote, use the protein efficiently that they were being given. And in fact, we don't necessarily know, but could this higher protein level actually be harmful to those sicker patients? A couple other points about this trial that were interesting to me. About a third of the patients were obese. And as you know, for many years, the practice guidelines for obese patients have advocated a lower calorie, high protein feeding strategy. And for those obese patients in this study, they did not see any clinical benefits for them as well, which kind of brings into question our current practices. And then last but not least, as I mentioned, these are basically medical ICU populations. So all of these patients, about 85%, had medical diagnoses. So we can't really generalize these findings to other groups such as trauma, burns, surgery, and things of that nature. There were a few other benefits of this study. It was certainly a pragmatic study. It looked at real life clinical practice, but there were a couple of downsides. The first, since this was a registry-based trial, the providers and clinicians were not blinded. And then the second thing that's interesting is that this study group received the same amount of protein for the entire 28-day study period. And the authors concluded at the end that, maybe patients needed a lower protein level earlier in their critical illness when they were sicker. And perhaps if they were making progress and going more towards a stable ICU or a rehabilitative phase, perhaps maybe on days 14 through 28, they could have benefited from a higher protein level. And that's just thoughts for future studies. We certainly don't know that answer, but it's an interesting thought. So at the end of the day, the authors concluded that they weren't willing to necessarily get rid of the ASPEN and ESPEN protein recommendations, which are 1.2 to 1.3 grams of protein per kilo, but then they qualified it by saying shoot for 80% of that goal. And one thing that I want you to keep in mind, especially as we talk about a case in a few minutes, is that actually, when you math it out, ends up being approximately 1 gram of protein per kilo per day. So now we're going to switch gears a little and talk about another big research trial that made news last year, and that was the NUTRIREA-3 trial. So unlike the EFFORT trial, this one was looking at both calorie and protein levels combined, so not just the protein levels that we saw in that first trial. And here's a brief outline, again, in this study that took place in France in about 61 ICUs. They were looking at these very critically ill patients and assigning them to a lower calorie and protein feeding strategy compared to the standard practices that are familiar to you from ASPEN and ESPEN recommendations. And I've included a summary of the findings from this trial as well. And it's interesting to note that the low calorie and low protein is in fact just what they promised. So in that first week of ICU stay, these patients were only getting 0.2 grams of protein per kilo and 7.4 calories per kilo, which for most of us in practice would just kind of blow your mind because it's not what we're used to seeing. And that's in comparison to the standard calorie and protein group, which received 0.9 grams of protein per kilo and 22 calories per kilo, which again is much more in line with what you're used to seeing with some of the practice recommendations. But then when the authors were able to evaluate the data for this trial, any of their clinical indicators and outcomes that we would typically be seeing, such as 90-day mortality, 28-day mortality, hospital or ICU mortality, as well as things like dialysis use, weaning of vasopressors, there was no significant difference between those groups, which certainly wasn't what the authors were expecting to find. However, when they did look at some of these other factors, such as mechanical ventilation weaning and GI complications, such as vomiting, diarrhea, and bowel ischemia, those were the areas where they actually saw a favorable outcome for the patients in the low calorie and protein group compared to the standard group. So that is certainly an interesting finding and not something that you maybe would have intuitively expected for patients who are only receiving 0.2 grams of protein per kilo and 7.4 calories per kilo. But again, remember that this was in that first 7 days. That's how long this trial was. So it's not that these patients were being fed at this low level indefinitely, but it seemed like at least during that first 7 days of ICU admission, there are some favorable benefits to feeding at a lower calorie and protein level. So this is fascinating to me because when we look at the conclusions of this group, you really couldn't say that we were harming these patients in this trial by feeding them a very low calorie protein diet. It really was basically safe, equally safe based on mortality. And then they certainly had some clinical significance to feeding at that lower calorie protein level, particularly with GI symptoms, which isn't really surprising if you think about it, because if you have an individual who is being fed gastrically and their body isn't in a position to handle all that nutrition, it's not uncommon to experience nausea, vomiting, and diarrhea. As we all know, a frequent reason for stopping feeds in the ICU. And then lastly, they didn't experience more adverse effects related to hypoglycemia, which is a bit interesting for a medical ICU population because we're often concerned that they're not able to produce enough with their liver to maintain their blood sugar levels when they're being fed such low levels of nutrition. But in this case, it must have been enough to prevent hypoglycemia, which is encouraging. So now we're going to switch gears and move on from those two papers and talk about how it's not necessarily a linear relationship between feeding more and providing more protein and positive clinical outcomes. So this paper is a little bit older, and I've included two of the graphs there for your reference. But when we look at ESPEN guidelines and ASPEN guidelines, we know that there is a detriment to underfeeding our patients over time, but there also can be a harmful effect of overdoing it. And perhaps there is a bit of a sweet spot where we're only feeding our patients 70% of their measured resting energy needs when they're in that very acute phase of critical illness. And likewise, there could be detriments to overdoing the protein, especially if patients aren't having strong kidney function, which is pretty common in this situation. For your reference, I've included a couple of slides that do go over the ASPEN and ESPEN guidelines, which I'm sure many of you are familiar with because they've been out quite a few years. The ASPEN guidelines are pretty static with a recommendation of 12 to 25 calories per kilo for those first 7 to 10 days of hospitalization. And then if you're interested in looking at the ESPEN guidelines, those are definitely a lot more nuanced. So they start off by recommending indirect calorimetry and then a stepwise approach where you incrementally increase the calorie level over the course of the first 7 to 10 days, and then proceed to even greater than 100% of resting energy expenditure when your patient moves on to more of a rehabilitative phase where they're hopefully recovering from some of the malnutrition that they're probably experiencing and trying to rebuild some of that lean muscle mass. And then if you're interested in reading further, I've also compiled some of the kind of quote expert recommendations that have been coming out with individual authors over the last couple years that are kind of looking to synthesize some of this newer study data, as well as including information about how we might have caution in feeding patients that are hemodynamically unstable. So same thing for the protein needs. I think I've already kind of addressed that the ASPEN guidelines start out at 1.2 grams of protein per kilo and ESPEN 1.3. But now again, when we're looking at some of the newer papers that are coming out, they too are recommending more of a nuanced approach where you perhaps start off on a lower end of protein, as low as 0.8 grams per kilo, and then move your way up once you know how your patient is doing, once you have a handle on what their vasopressor requirements are, and also their renal function. I've included a slide or a representation so you can see theoretical models that have been published in the last few years to kind of get at this concept that maybe our patients' calorie and protein needs really aren't static and that they can change during the course of a critical illness. So in line with what the ESPEN recommendations are and what some of these newer trials are seeming to point us towards, it might be that we have a place where in those first maybe 1 to 4 days of critical illness, we're very conservative. We still will get our feeding started within the first 24 to 48 hours, but we might only be giving 25% or 50% of what their estimated needs are, and then incrementally moving up as the patients stabilize. And it's important to recognize that our patients aren't following this neat linear model. They certainly can experience any kinds of setbacks or a new infection or something like that that could cause you to maybe have to go from that post-ICU phase right on back to the acute phase. And maybe there might be a time where you have to back off again on the level of calories and protein that you're providing your patient and work back up again towards those rehabilitative goals. So I know this is a lot of information to process because I feel the same way, even having done this for a lot of years. But I thought it might be useful to do a quick case study and see how you might be able to apply some of this newer study data into your recommendations for caring for your patients. So in our case that we have here today, we have a 73-year-old woman admitted with influenza A. She's intubated in the emergency department and arrives in the medical ICU. And unfortunately, just like for those of you who worked during COVID, she is put in the prone position, and then she starts needing all the usual therapies, such as getting central access and starting on a vasopressor. Her past medical history, fairly straightforward, COPD, diabetes, high blood pressure, breast cancer, which is in remission, and obesity. And I've listed some of the anthropometric information for you, as well as the nutrition-focused physical exam findings. And essentially, this is an individual who is obese based on her BMI, which I know is a hot button topic in and of itself right now, but be that as it may, her BMI is over 30. And then she's showing some physical assessment signs of malnutrition based on mild muscle loss and some edema. On the second day of our patient's ICU stay, she's cannulated for ECMO because of her severe ARDS. Thankfully, she's only requiring 1 vasopressor at a pretty modest dose of 0.1 micrograms per kilo, and she is receiving propofol for part of her sedation. So as you would expect, you get the call and the consult to get nutrition going. As I mentioned previously, she would meet the criteria for acute malnutrition based on those physical exam findings. And when you start your assessment, you can look at her labs and see that she's got an elevated blood glucose, which would be reflective of that inflammatory process and the stress that her body's experiencing. And then her BUN and creatinine are elevated, modestly so. And her potassium and phosphorus are fairly unremarkable. I know where I work, the potassium is still within normal limits at 5.1, but it's certainly getting close. And that would be something you'd want to keep your eyes on to see which way that's going to trend. So as we're doing our initial nutrition assessment, first and foremost, we need to think about route of feeding. And I know that this can vary by hospital, and it can definitely vary by physician preference. It even varies based on whether you're in the United States versus Europe, as an example. But that being said, when we look at the research, for most of our patients, gastric feeding is just fine. If you do feel strongly that your patient's at high aspiration risk or there's other issues or feeding intolerance, you certainly could pursue post-pyloric feeding. But I always caution people that you don't want to pursue post-pyloric feeding if you're not going to be able to get access and it's going to delay starting nutrition. just by trying to get that feeding tube in the most perfect position. So that being said, for the most part, our patients certainly should be an appropriate candidate for gastric feeding. So first and foremost, if indirect calorimetry is available, that's lovely. And practice guidelines, including from ESPEN, would recommend that you would start off potentially at that 65 to 70% of what you measure through resting energy expenditure. The ASPEN recommendations would be a little bit different because this patient does have obesity. So that would be looking at 11 to 14 calories per kilo per day, which gets you in that 975 to 1240 range. Then the actual ESPEN guidelines get a little bit more complicated because they suggest using an adjusted weight, which could be either the equivalent of a BMI of 25 based on the patient's height, or using an ideal body weight and adding a 25% fudge factor. Now, in the ESPEN recommendations, they don't specifically say how you calculate the calories. They're just talking about whatever method you use, these would be the weights that you would use. And I've included for your reference that if you math that out based on this woman's height, you're using a dosing weight with the ESPEN guidelines anywhere between roughly 63 to 65 kilo. And then lastly, some people would still suggest 25 calories per kilo of ideal body weight. So that gets you to 1,300. And then you'd want to be factoring in the propofol calories. So whichever way you go about assessing energy needs here, it's nice if you have the ability to pick a couple different methods and compare and contrast. And usually you'll end up with something that seems to be a decent range, such as in this case, maybe 1,000 to 1,300 calories per day. If you see something that's a real outlier of 500 to 600 calories different, you certainly want to go back and check your math to make sure that you didn't do something incorrectly. Now we'll take a second and talk about protein goals for this patient. She does have acute kidney injury, albeit modest acute kidney injury, but we certainly don't want to do anything that could potentially exacerbate that, especially when we're first getting started. So if we go back to the author recommendations from the EFFORT trial, that would give us 1.2 to 1.3 grams of protein per kilo, feeding 80% of that, and again, using that BMI of 25. So I've done the math for you again on how you'd go about calculating that. And after you've gone through those steps, that ends up being about 60 grams of protein for the day. If you go back to earlier in my presentation, I told you to remember that this ends up being about 1 gram of protein per kilo of your dosing weight. And you can save yourself a lot of mental math if you remember that. And then lastly, especially when we're feeding at a lower calorie level for that first maybe week of hospitalization, starting with more modest calorie needs, it's probably not likely that you're going to meet your patient's micronutrient needs. And that would be something that you would want to consider whether or not supplementation is appropriate, particularly if your patient had been sick and eating poorly prior to their admission. A few practical applications to round out our discussion today. As we all know, any of these patients in a medical ICU setting can be very complicated. They can have a long list of past medical history, and then once they get into the ICU, anything can happen, and you can be juggling a lot of different issues based on disease state and their organ function. So you do need to get comfortable kind of juggling all of those things and prioritizing what you're most concerned about. That being said, though, it's an exciting time to work because you can be constantly looking at that patient data, looking at the research findings, and then seeing how your patient responds to what you're doing and adjusting your plan accordingly. If I can leave you with anything today, it's that you need to keep being a good critical thinker and seeing how things are going and recognizing that you can't put your patient on a standard tube feeding on hospital day 3 and just go on autopilot. You're probably going to need to do some adjusting over the course of their hospital stay. Another thing to always be cognizant of is all of those medications, working with your pharmacist, making sure that you're on the same page to see how medications such as propofol or bowel meds, steroids, or insulin could be affecting what it is that you're trying to do. Staying on top of whether or not your patient is having any issues with wounds or pressure injuries that might make you think about when you're going to increase your protein level as the patient tolerates it. And then certainly if you work at a facility that has indirect calorimetry or other body composition tools, how are you going to incorporate those into your practice so that you can keep adjusting the nutrition goals for your patient? And then working with other therapies such as physical therapy and occupational therapy, and touching base with them to see what they're seeing as they work with the patient, to know whether or not, they're making progress with both maintaining their lean muscle mass and physical activity. Because at the end of the day, certainly the goal isn't just to live through the ICU, it's to function well and do well in that rehab phase and hopefully forward once they recover from that acute illness. So with that in mind, I'd like to wrap up our discussion today. I know it was a lot of information, but I appreciate you watching, and we look forward to having you join us for the next DNS YouTube video. Thank you.